At this time, I would like to introduce you to our speaker. Clint McKinney has worked in healthcare for over 30 years, including 14 years as a rural family physician, practicing the full scope of family medicine. He has both owned a private practice and worked with large healthcare systems. He also worked for 8 years as a national rural healthcare consultant in over 50 rural communities. Dr. McKinney currently works as an emergency department physician in rural Minnesota. Dr. McKinney is Clinical Associate Professor in the Department of Health Management and Policy at the College of Public Health, University of Iowa. He is also Deputy Director of the Rural Research Institute, or RUPRI, Center for Rural Health Policy and Analysis. Dr. McKinney has been a member of the RUPRI Health Panel since 1998 and has served on national committees for the Institute of Medicine, the Department of Health and Services, the American Academy of Family Physicians, and the American Medical Association. Now I will turn it over to Dr. McKinney.
Well, great. Thanks, Kim, and thank you all for joining us this afternoon. The title of my talk is Chasing Zero, the Journey to Rural Hospital High Reliability. You know, I've been talking about patient safety for, gee, many cats, maybe 15 years or something like that. But I got re-energized about this with a hospital that I'm working with in Alaska, Central Peninsula Hospital in Soldotna, Alaska, who is embarking on a journey to high reliability, or wanting to become a high reliability organization. So with that in my back pocket, I decided to do a little bit of research about this and learn a bit more about high reliability organizations and their place in healthcare. The name Chasing Zero comes from a project that's been started by the Texas Institute of Medical Technology, and you may kind of recall some of the work by Charles Denham in this organization. They also used a fairly prominent actor to help support the project or endorse the project, and that was Dennis Quaid. And again, this was some time ago, but Dennis Quaid and his wife had twins born at a hospital in Los Angeles, and the twins were overdosed on heparin, a blood thinner, and evidently almost died. So Dennis Quaid supported this organization to help reduce the chance of medical error. Now, one of the parts I really want to stress as I give this presentation is that, number one, there's really no such thing as a high reliability healthcare organization, and I'll define what that means. But that doesn't mean that the journey to becoming highly reliable and safe isn't critically important. And I'm hoping that after this talk, you'll share my concern about the safety of healthcare in the United States, and then also maybe pledge to be one of the safest hospitals in your region. And I think all of us can do that. So here's kind of the plan for today. First, I'd like to just refresh everyone's mind about how important of an issue this is about patient safety. We'll talk just a little bit about how harm and death occurs, and then I'll describe what a high reliability organization is, and then lastly talk about the rural hospital journey to that high reliability organization status, or moving in that direction. It does start first with this. This is the Triple Aim, and I hope all of you are familiar with it, and I encourage you to help your boards and your community leaders understand it as well too, and its importance. I often will introduce the concept of the Institute for Healthcare Improvement's Triple Aim, or CMS, who's kind of co-opted the concept from Don Berwick when he was at IHI, and then he was briefly at CMS. As you know, if you were to sit down with anyone, almost anyone in the United States and kind of have a beer with them and kind of talk about healthcare, almost all of them would say that they want to get better when they're in the healthcare facility, that they want to be treated with respect and compassion, especially during such a time of such vulnerability and frightening episodes, that they want their families, neighbors, communities to share similar good health, and that they'd want their hard-earned money to be spent wisely and not be duplicated or wasted on duplicative services or unnecessary services. And of course, what I'm talking about is the triple aim. And sometimes what we forget in that middle part of the triple aim, the better patient care, is also safe patient care. And we should expect when we enter a hospital or we enter a practice that we're not only going to be treated with science-driven, high-quality care designed to improve our health and our productivity, that we would expect to be treated with compassion and respect, but also that we would be treated safely, that we wouldn't be harmed. But indeed, we are harmed at a frightening rate in U.S. healthcare facilities, and I imagine also around the world facilities as well too. So you may or may not recognize this character. This character is Hippocrates. Hippocrates famously said primum non nocere, which means first no harm. But if we were to talk to our patients and translate that, it might be translated to please don't hurt me. And some really forward-thinking people in the United States have talked about this and talked about it quite a bit. If you haven't read this book, Crossing the Quality Chasm, don't necessarily read the whole thing, but go to the Institute of Medicine's website and download the executive summary, which is only like 18 or 20 pages. It's just fabulous. It's just fabulous. And in it comes the 6 aims for the healthcare system. And that is that the healthcare system be safe, effective, patient-centered, timely, efficient, and equitable, or fairness, or fair. But let's go back up to safe. And that's what we kind of want to concentrate on now. And notice that the authors, Mark Chasin, the authors of this book, put safety as their number one aim for the healthcare system. Number one. So let's move ahead just a little bit. So moving ahead is this slide from Deaths from Medical Error. So shortly after Crossing the Quality Chasm, and I'll show a screenshot of it here in just a minute, was a book called To Err is Human, where the Institute of Medicine estimated 198,000 deaths per year from medical errors. And now Johns Hopkins in 2016, Johns Hopkins researchers estimated 251,000 deaths per year. Now put that in perspective. That's 10% of U.S. healthcare, U.S. deaths are due to medical errors. It's kind of like guns don't kill people, doctors kill people. So 10%, and that makes medical errors the third most common cause of death in the United States. And that's based on death certificates in which the medical error is actually identified. There's certainly other places where the medical error might not be identified but still cause death. So this is really critical. Then in 2013, the data that was used for this research from Johns Hopkins made medical errors the third leading cause of death in the country. And that should frighten all of us. It should. And you need to put it a little bit in perspective, and this has been done elsewhere. But if we really think about 2 large airliners crashing every day and killing every passenger on board, would you fly? Would you fly on an airline? And this is, of course, just after the news in the past 3 days or so about airlines having their safest record ever. So I asked kind of the question rhetorically, because I fly a lot, would we fly? Or would we become simply numb to the numbers? Maybe a physician talking about patient safety really shouldn't quote Joseph Stalin, but Joseph Stalin said, when one person dies, it's a tragedy. When 1 million people die, it's a statistic. So I describe this as a cruel inhumanity. And it's probably true, unless it's you or me or my family or my friends who are in that statistic. So let's kind of keep those numbers in mind. I would ask a personal favor that you don't let the numbers make you numb. This happens to essentially almost all of us. Let's please keep that in mind. Now, also an important thing to keep in mind is that we're human beings. So when we say medical errors, it shouldn't be unexpected that human beings make errors. I've got a couple of slides here of a guy on this rickety ladder changing a light bulb, and another guy standing on an aluminum ladder in his bare feet using a power tool that's plugged in. We do stupid things as human beings. And as I told you, I work in an emergency room. This is an X-ray of somebody going ka-chunk, 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 ka-chunk with their air power framing nailer, and decide they want to just nail their femur here or their knee. So we do crazy things here, and we can't be expected to operate perfectly as human beings. So the way the researchers categorize these medical errors or errors per encounter is in this way. And you've probably heard of Six Sigma. Six Sigma was generated by General Electric as a way to reduce manufacturing errors. And they shoot for Six Sigma, and that would mean in kind of statistical terms, and sigma as a measure of variation, as 3.4 errors per encounter. So that's 3.4 per million encounters. And really, human beings just can't do that. And then we drop down to something that's a little bit less safe, but pretty darn safe. And that is this less than 1 encounter per 100,000. And that's where nuclear power plants sit. That's where scheduled airlines sit. And who knows, with scheduled airlines, that may be even getting better. And then a little bit less safe, more dangerous, is probably someone you know. This is in the range of greater than 1 encounter per 100,000, but less than 1 encounter per 1,000. So you can see there's a tenfold difference there. And this is driving and chemical manufacturing. So I'm sure almost all of us have had friends or acquaintances who have been killed in driving accidents. And then I wrote here, this might happen to you. And if you're not a bungee jumper, all of us at some time in our lives will access health care, or essentially all of us will access health care. So this is kind of the level of it that might happen to you, and this is where we are in healthcare right now. I mentioned Six Sigma. This is just a graphic of what Six Sigma looks like. And Six Sigma, again, refers to 3.4 errors per 1 million tries. But there's been some estimates that humans make an error every 100 tries. And as I think about how I use the electronic health record, hopefully I'm not using it or making mistakes with it that necessarily harm patients. But holy smokes, it seems like about every hour I forget to click a button or do something wrong on that thing. And so I make an error with it. So the key is, can we set up systems? Can we set up systems in our medical care that help protect our patients from the inevitable human errors that occur? I wrote here that there's no hospitals that are at Six Sigma, but we can be much, much safer than we are. And the key to this is high reliability systems compensate for the limits of human ability. I'd like to show you this graphic, if I could, and also read this text from the Institute for Healthcare Improvement. And the title of the slide is "The System, Not the People." And the text says, despite the best intentions of a dedicated and highly skilled workforce, our system, which intends to heal too often does just the opposite, leading to unintended harm and unnecessary deaths at alarming rates. And I want to use this graphic as a very quick example. Those of you who are clinicians and you look at those chest x-rays, those are chest x-rays that are thrown up on the graphic, may see that something is wrong there. Those chest x-rays are put up backwards. So in essence, you see a shadow within the darkness of the chest that is really kind of looks a little bit like a triangle in the darkness. That's the heart shadow, and it should be on the other side. So these are x-rays that are put up backwards. And I had an episode when I was working with a hospital where they're telling me about a patient who was T-boned in her minivan by another car, and she came to the emergency room early in the morning with a collapsed lung. And the treatment for a collapsed lung is that you put a tube into the chest, you place the tube in the chest to re-expand the lung. And the story was that this was a change of shift time for the doctors at 8 o'clock in the morning. And the new doctor coming on said, don't, to the old doctor, the doctor who's leaving, said, I'll take care of this, don't worry about it, you're tired, go home, go to bed. And one of the system mistakes that happened was the nurses were changing shifts at the same time. And this was a doctor who took over, was very well respected, very well liked, not one of those doctors that throws things and crabs at nurses and other staff, very well liked, very well respected. And he started to put in the chest tube, and a paramedic is standing in the corner, and the paramedic is saying, I think it's the wrong side. But she wasn't given the opportunity or maybe the power within that ER room to be able to speak up. And indeed, the well-intended, well-respected physician put the tube in the wrong side. The patient did not get better, as they usually do with this maneuver, and they realized the error and put the tube in the proper side, and the patient improved. So this was a really good example where the systems probably let that patient down. Now, she didn't die, but probably let that system down. And the truth of the matter is every system is perfectly designed to produce exactly the results it produces. And if it's designed to not catch these kind of errors, then they're going to happen. This error happens these ways, and if those of you who are familiar with quality improvement research would be familiar with James Reason. James Reason talked about the Swiss cheese process of medical errors. That medical errors have to actually occur with breakdowns in the system in multiple spots. And they show 5 pieces of cheese here, and it has to all get lined up perfectly for harm to occur at the patient. I won't discuss this, but as you think about quality improvement and patient safety in your hospitals, think about James Reason's model of the Swiss cheese and how errors occur. And also, as we think about where errors occur, this is our opportunity to short-circuit patient harm. This is where we can make a difference. So keep that model in mind as you think about it. Now, also a thing to keep in mind as we think about patient safety and quality improvement in our organizations is these are often cultural processes, especially as we think about patient safety, and I'll talk about further about high reliability organizations. So let me step back for a moment and talk about culture for just a moment. Whenever I hear many organizations talk about culture, they're talking about the way management treats employees. And culture is so much more than that. Edgar Schein wrote that culture is the residue of success. He's a really great organizational psychologist. He wrote, it's a residue of success. I think that's beautiful, but even he would probably argue that it doesn't guarantee future success as things change. So it's also been said that culture is an environment of behaviors and beliefs. And what I've said is culture is what we do, and culture is what we become, we do, and then what we believe. So what we do becomes what we believe. So it's based on behaviors, and that's really key. Culture has been said is what we do when nobody's watching. So it's a set of behaviors based on what we believe, but the behaviors can drive the belief system. And it's measurable. It's measurable as well, too. So here's some of our cultural barriers. I call it healthcare's Dr. Evil, and I don't need to read all of those, but you probably know them. You know, feeble teamwork, especially with my colleagues as physicians, as Iron Man mentality, and we just deny that humans are fallible and humans are going to make mistakes. They just do. They just do. So let's design our systems to counter this culture right now of our evil. And this is probably one of our worst cultural barriers, and that is, and it's always said this way, but Dr. McKinney, because we do that because we've always done it that way. And I would strongly encourage you to get that language entirely out of your organization. We always can improve and we can always change, and here's our worstest cultural barrier. Now, as I've talked about management in the past, I've often talked about kind of 4 pieces of the puzzle all fitting together that are all important. And those are safety and quality and patient experience and employee growth and financial stability. And I'm going to make a case or try to make a case here, and you can push back and you can think about this. Is it appropriate for us to prioritize safety and quality above all other balanced priorities in our organization? I don't know the answer to that one yet, because I think we do need a balance as leaders in healthcare organizations to ensure that we serve our communities well in perpetuity. And if we can't do that, we're not going to be there to provide safety and quality. But the researchers in high reliability organizations in healthcare would argue that we need a cultural imperative that quality, safety, and quality be number 1. That be our highest priority as we look at our operations, we look at our employees, we look at our budgets. So I'll let you think about that, but that's what I wanted to just tell you is actually happening. So let's talk a little bit about what a high reliability organization is. So a high reliability organization operates in complex and high hazard domains. Man, that is us. Yes, it's aircraft carriers, and yes, it's nuclear power plants, and yes, it's scheduled airlines. Those are the examples that you read about in the literature, but it's certainly healthcare. One of the most complex organizations on the planet is a hospital. It's a hospital. It's complex and it's high hazard. Now, these high reliability organizations go beyond standardization, and I talk a lot about reducing variability in our processes in healthcare, but it goes beyond that to persistent mindfulness, always on the lookout about how processes or current operations can or likely will hurt our patients or harm our patients. That's the anticipation, so that they can be detected, so potential problems can be detected early to prevent catastrophes. Studer, you may be very familiar with the Studer Group, is doing a lot of work around this as well too, along with organizations like Planetree as well too. So Studer Group says that a high reliability organization implements predictable and repeatable care systems. Why? Why is that? Predictable and repeatable care systems reduce variation and thus reduce the opportunity for harm. They call for consistent execution of operations and protocols. In fact, there is not kind of a different way of doing the same thing. We do it the safest way. And what we find in healthcare is that we as healthcare providers often are rewarded for finding workarounds and processes that we either think are more efficient or maybe even help the patient. So how many times have we figured out workarounds for that wristband code, that the wristband barcode that doesn't work right? Well, the right answer to that question is to call on your managers to fix the problem so we don't need to do a workaround. This process reduces variation. That's the idea. We want to reduce variation, not simply chasing averages. And here's a tough one. Here's a tough one. It's not just performance improvement. We're examining the habits of people. So that's why I use workaround as an example. We're examining the habits of people that well-intended, remember, a well-intended workforce, but are operating in an environment or with variation of process that increases the chance of harm to our patients. This is exquisitely hard. This is exquisitely difficult to get our hands around as well, too, because most of us who have had at least some training in quality improvement tend to think of our standard tools in quality improvement to improve the processes of care. And they're still valid. I'm not saying we give up on root cause analyses and failure modes and effect analyses and wishboning. And those of you in quality improvement will understand those tools. But those tools are different than examining the habits of people. And that's where we need on the ground, in the processes themselves, managers to help us understand where the variation is and where likely harm will occur. Now, okay, so I've talked about what a high reliability organization is. I've spoken about what the degree of harm is and how we should all be both alarmed and frightened and moved to action because of the harm that's occurring to our patients in our charge. But I like this cartoon, and the cartoon is they're looking at a mathematical model on the chalkboard. These two scientists, and on the chalkboard it says, "Then a miracle occurs in the scientific process." And one scientist says to the other, "I think you should be more explicit here in step 2." So I'm going to try to be a little bit more explicit in step 2 rather than a miracle occurs with this. I kind of talk about it from getting from here toward there in this high reliability journey, the journey to high reliability, which, oh, by the way, is now, this is from Joint Commission. So I've mentioned already the Studer Group. I've mentioned Planetree. Now I'm mentioning Joint Commission. And lastly, the Agency for Healthcare Research and Quality, or AHRQ, are all great resources for this. And also, just parenthetically, I have a list of resources for you at the end of the slides. So getting from here toward there, it's where you start is really, I think, less important here. Instead, it's a relentless commitment to safety. And it becomes a cultural commitment to safety. And again, I'll talk about that in a little bit more in a second. But remember, culture is behaviors. Culture is behaviors. How do we act when no one is looking? It's behaviors. And I argue that they're measurable. So even though relentless commitment to safety sounds a little bit pie in the sky and a little bit kind of squishy and hard to get your hands around, I do have some specific ideas for you. And they're taken from some sources that you'll see at the bottom of the page here. So these are 5 traits of a high reliability organization. I won't go into the details of them because you'll see them on the screen, but I want to at least list them so you have a sense of what these traits are. Okay, now again, when I very specifically talk about traits, I talk about behaviors. So I'm trying to make this more tangible than simply culture, which again is kind of squishy and hard to get your hands around until you start thinking of culture as behaviors. And it's not just behaviors of we as individuals. It's not that. It's also behaviors of the organization. And what I mean by that is, what are the policies and processes for the organization? What's in your policy handbook? How do you set up your budgets? How do you design job descriptions? How do you reward employees? How do you set up employee performance evaluations? How do you do yearly awards, employee awards in an organization? These are all organizational behaviors. So when I see an organization that says, we are all about quality improvement, and then I look at their budget, and then quality improvement has, I'll make a number up, has a 0.25% expense line for the budget. I'm going, now wait a minute. Tell me again how this organization is all about quality improvement. When I look at a board meeting agenda and I don't see anything on that board meeting agenda about quality improvement, tell me again how this organization is all about quality improvement. So what I just described, those two examples, those are organizational behaviors. It's not what's written on the wall. It's not what the CEO says. Those are organizational behaviors. And sometimes it takes someone who's from outside of the organization looking in to help you understand what are the behaviors that are describing the culture of this organization. So 5 traits of a high reliability organization. Preoccupation with failure. This is encouraging near-miss reporting. This is what this is. A reluctance to accept simple explanations. So this is also a part of a little bit of root cause analysis, and it's asking why, trying to look deep into why things occur rather than accepting kind of standard pat answers. And they also use data to challenge long-held beliefs. We always do it this way. Now, wait a minute. Let's use some data to really explore if doing it the same way we've always done it is the right way. We're sensitive to operations. This is part of rounding, or leadership rounding. I'm hopeful that you on the call who are hospital leaders, whether you be the chief nursing officer, whether you be a chief financial officer, whether you be the chief executive officer, that you round regularly. And to the point of simply, this doesn't need to be formal, but it's simply saying things like maybe two questions. First, what's really bugging you these days and how can I help? Number 2, what are you seeing that's likely to make our patients unsafe? What are you seeing? And also, that's actually a good way to kind of look to new employees. As a new employee is been in the organization for 2 or 4 weeks, interviewing that employee, what do you see here that we could be doing better compared to what you had at your old employment? That's a deference to expertise I'm describing. That's asking and listening. And also scheduling, for those of you who are the schedulers of meetings, kind of scheduling no meeting zones. So then when that other employee on the leadership team, the other leader says, oh, I just didn't have time to round today, you say, no, wait a minute. We specifically set aside time in your day where we never schedule meetings. There's no excuse for not having time to be leading. And then seeking out fresh perspectives from new employees, that's what I just described. And then lastly, commitment to resilience. So we just assume right away that the system's at risk for failing. Let's just assume that. And now we use the tools to help make it safer. And we use situation assessment. This is asking our employees to continually to scan the environment. What's likely to get injure a patient here? And then when we do that, help them understand why. Do we have a shared vision in this organization? Every management course I teach, and I teach at the University of Iowa Healthcare Management, University of Iowa, we talk about this, and it just comes up every single time in every management text you read. The importance of sharing the vision so the whole organization understands it and buys into it. That's sharing a vision, and the vision may be, we will be the safest hospital in Southeast United States. You pick one. Pick one. So I'll come back here to the chasing zero. And I'd like to describe just briefly Central Peninsula Hospital. So Central Peninsula Hospital is a rural referral hospital on the Kenai Peninsula in Soldotna, Alaska. Very progressive CEO, very progressive hospital. And they took upon themselves to say this: we are committed to zero preventable harm by 2021. And that's preventable harm, get this, not just to patients, but to their staff as well too. Now, if there is a better example of a big audacious goal, I don't know what is. But imagine you all at your organization saying, we are going to commit to zero preventable harm by 2021. Now, there's a lot of work that goes into that. There's the work of, for example, deciding what's preventable harm, how are we going to measure it, what's our denominators going to be. But nonetheless, the point is this is their organizational goal, and they've turned it into a value. Probably most of you in your hospitals have, we'll say, a half a dozen values that you post on your website or post under About Us. You have values. Well, safety is going to be a value at Central Peninsula Hospital. So that's one of their values. They have a yearly employee value award, or an employee who exemplifies or lives one of their half a dozen values is rewarded each year at their awards banquet. Well, now they'll have a safety award as well too. There's transparency in the organization. So what they do at Central Peninsula Hospital, they have a daily safety huddle. That's taken work to try to figure out things like, what do we discuss here? How do we get our department managers to go out there amongst their employees and ask, what are the safety problems that you see right today, so I can report them? So it's taken work and effort, but they're doing it. They're transparent also about their performance. It's included in board reports. It's included in Hospital Compare. It's included in Leapfrog. Now many of you are not involved with Leapfrog, but those of you who are on probably are involved with MB-QIP. And so even making sure you're reporting to MB-QIP and discussing those results is a good start. And then safety data is openly available and discussed. So it's discussed among the leadership team and also discussed at the board, which is of course, your conduit to the community. There's measurements and transparency issues that go hand in hand, and people wiser than me have said, to improve a process or to improve a performance, you must measure it. And that, I think that's indeed true. Measurement adds something else to it. Measurement tends to force attention, which is critically important. If I'm working in the emergency department and the CEO passes through and says something to me like, Clint, gosh, man, you're doing a really good job down here in the ED. We get some really good reports from our patients. Thank you so much for doing this work. But you know what? I've been tracking on your wait times in the ED, and they're starting to creep up. We track that monthly. Would you kind of check in on that for me, get me an improvement plan so we can start tracking that and see some improvement? And then if the next day the board chair walks through and says, oh, Clint, I wanted to introduce myself. I'm the board chair. Thanks very much for your really great performance here. We hear great things about your department. But gee, we do track wait times in the ED and they're starting to creep up. The board reviews that every month. Would you help us and get that better? What do you think? Do you think I'm just going to ignore that? No way. That is attention to measurement, attention to performance. That's the currency of leadership. If leaders want to get something done, they attend to it. They don't abdicate it to someone else. Or if they do, they make sure that person has decision-making authority over that issue and that they track on it as well too, even though another person may have kind of decision-making authority. So we need to kind of decide what is this harm that reaches the patient? Is it a sentinel event? That's from Joint Commission. Is it a patient safety indicator? That's CMS. Or is it serious safety events from the Association of wait a minute, ASHRM. Anyway, I'm not going to be able to come up with the acronym for you. I've got it in the notes, but nonetheless, that's what CPH uses is serious safety events that they're using for theirs. The other issue that they had was, so they want to find out what harm is. So what is a serious medical error? What's a harm to a patient? They also want to kind of figure out, how do we measure this? So they didn't really like the idea of days since harm. That's what a lot of industry does. You've seen that before. 300 days since missed work injury or something like that. You'll see that on manufacturing plants a lot. So they didn't like that as much. So now they really like a rate better. So now they're struggling what the denominator is. The denominator in patient days. They're probably going to be using adjusted patient days, but they're probably, and those of you who are kind of not the finance people, that's a way of looking at the total days that you have patients in your hospital divided by a value that recognizes outpatient revenue. But nonetheless, adjusted patient days is what they're probably going to be landing on. But the point is, you do need to kind of come up with a denominator. So this work of measurement isn't just a slam dunk. It takes some effort to be able to do it. But those of you who are interested in quality improvement already will have the kind of the tools and the experience and the resources at your disposal to be able to do that. And if you run into a bind, the National Rural Health Resource Center will have resources for you as well. Rural Health Value, the organization I'm working with, will. And heck, you can just email Kim or me, and we'll put you on to the experts in the country about this. So we have process improvement that's focused on safety. If we kind of think about it this way, it's kind of Murphy's Law. If we come in at it with this, that anything that go wrong will go wrong. So if we think about it that way, this is kind of understanding that things are going to get screwed up here. But our goal is to try to reduce the chance that screw-ups are going to occur to the point where they hurt a patient. And I've listed a few things here, like PDSA, Plan, Do, Study, Act, process maps, failure modes, and effect analysis. These are all, again, tools that your quality improvement directors will understand well, and they get us there, but they're not, these are tools. They're not cultures. They're not cultures. But let me also talk about a couple of others. Debriefs, and this is something I've recommended to hospitals, and I think it's really good and very applicable for us in small rural hospitals. And that if we have a debrief and we have an analysis, for instead of those situations where things don't go right, this is the classic problem with peer review, which just grates my nerves. If we instead said, let's review all high-risk and low-frequency events and try to understand ways that it went well and ways that we can improve it, that would be a much better way of doing, in my opinion, peer review. So in my place, and this is probably similar to you guys, is that the high-risk events for us are stroke, STEMI, or acute myocardial infarction, acute heart attack, stroke, multiple trauma, sepsis. So those are, if you hit on those four right there, all high-risk and low-frequency events, that would probably be pretty good. A pretty good way to get started at this. Other thing I alluded to a little bit earlier, we talk about this in my management class. We talk about first-order and second-order problem solving. So workarounds are first-order problem solving. You're a good employee because you figured out how to get around the system and take care of your patient. Well, it shouldn't be that. I don't think it should be the employee's job to fix that. It's the manager's job to fix that. So the manager's job is to identify when those workarounds occur, and then get his or her hands dirty to fix the process so it doesn't need to occur. Now, maybe the workaround is the right way to do it, but we don't know it is until we get in and investigate it. So the key takeaway from this slide is that even though I've listed some tools, PDSA, process maps, FMEAs, debriefs, first order and second order problem solving, those are tools. Those are tools. Working toward a high reliability organization is more than that. It's a cultural focus on looking for not just variation, but potentials for error and harm to occur, and then designing systems to short circuit those processes or change those processes so error is much more likely or much less likely to occur. It's a value. And I know that this, again, is a little bit squishy when I talk about culture, but safety can be an organizational and publicly shared value. I mentioned before, it is manifest in organizational behaviors, not just people behaviors, but organizational behaviors. How you do the budget, how you set up your operations, how do you write your job descriptions, how do you do your job evaluations, your performance evaluations for your employees. If safety is an organizational and publicly shared value, you will see safety or high reliability show up in budget and operations and job descriptions and performance evaluations. We do have a leadership role. It certainly, admittedly, the organization does emulate the behaviors of the leader. So when the leader is asking about patient safety concerns on his or her rounds, that's called management by walking around. That is a behavior that translates to individual employees or associates. That leader needs to be expert, not only communicating down to the employees, especially around a shared vision, but communicating up. That is the listening part. So leaders need to be able to communicate down, and we need to be able to communicate up. We encourage everyone to continue to look for something that's not quite right, something that could potentially harm our patient, and we then underscore that safety is paramount. Now that takes me back to remember that jigsaw puzzle slide that I showed quite a bit ago. I've often said, and been saying for probably 20 years, that one of the things that leaders, both in nursing and in physicians and in finance and in community, do wrong is not understand that a CEO needs to balance different priorities. We need to balance priorities. But I'm going to ask you rhetorically, and think about this, and maybe a discussion to have in your own organizations, even though that's probably true, we need a balance between our employee growth and development and a balance between our financial success, a balance between our community and community mission to serve our communities, and then patient safety and quality. Should patient safety and quality be paramount? And again, I don't have a quick answer for you, but I think it's important to discuss. I won't talk too much about just culture, but I want to simply mention it because every time I think I get into the discussion about the importance of system changes, not employee behavior changes, that employees are all of us, we have a well-intended and highly skilled workforce. When I say those words, invariably, somebody is going to either say or it's going to pop in their mind, what about that jerk who never follows the rules? I don't care if you tell me I have to wash my hands before seeing patients. I'm not going to do it. What about that person? What about that person? And this is where the idea from Just Culture comes from. So Just Culture was championed by David Marks, again, probably about 15 or 20 years ago. And it's really an important concept because even though I say it's the system, not in the employees or not the associates, well, that's not always the truth. So let me read this. A just culture recognizes that competent professionals make mistakes and acknowledges that even competent professionals will develop unhealthy norms. Again, I talked about shortcuts or workarounds or routine rule violations. But a just culture has zero tolerance for reckless behavior. So if we have someone who is willfully and destructively not following established science-driven processes, that's reckless behavior. So frontline personnel should feel comfortable disclosing errors, including their own, but while maintaining professional accountability. So that's the professional accountability. As a physician, as a nurse, as a therapist, I will make mistakes. But I do so with a willingness to be accountable for them and a willingness to change and a willingness to follow the rules that are designed to help me make my patients safe. So this is what you can do. This is what you can do. First, let's educate our caregivers about risk. We need to stop denying human infallibility. We need to stop accepting the idea that nurses and physicians are iron men and women. We need to hold our caregivers responsible to follow best practices. I've said many times that I really don't care too much if the care we deliver varies by the patient. But I got a problem if it varies by the doctor or the nurse or the time of day or the day of the week. If it's varying by one of those variables, characteristics, I would ask, why does it? Now, maybe we don't have good science to drive what the right process is. Maybe we don't. And if we don't, let's say that, and maybe we can design, maybe we can understand the science. But until you show me that, I want care to be pretty darn similar among doctors and nurses and therapists, other clinicians, and time of day and day of the week as much as possible. On the other hand, if we say, well, this patient is elderly, and therefore we're going to change our process a bit because of the coexisting conditions, that's perfectly acceptable, We want to create a safe haven around reporting. Again, when an error occurs and someone reports it, the first words out of somebody's mouth in management or leadership should be thank you. Only through this kind of process can we make it better for all of us. Thank you for helping this organization. And then recognize what we can and we can't control. Also critical. Here's another quick slide on just culture, how just culture builds trust. It promotes reporting and fosters mindfulness. And again, that mindfulness is what's different about, I think, what I'm talking about today as opposed to our typical QI. This is cultural. It's a systemic approach to error reduction, and that means a cultural change, different than what I've been kind of talking about previously with quality improvement. I won't go through this entire slide. This was presented by the Chief Nursing Officer at Central Peninsula Hospital, but it talks about kind of a changing of perspective. And my suspicion is that probably most of us are at stage 1 and maybe kind of getting into stage 2, and we're not to stage 4. I mean, as I said before, it's not really where you start the journey. It's that you're moving in that direction. So I wouldn't ever beat someone up for saying we're just in stage 1. Instead, I'd beat us up for saying, I don't know where we are, and I don't care where we are. I think we should be moving towards stage 4, and that's indeed the journey. So how do you sustain the journey? And this is where I've been working with Central Peninsula Hospital, and they frankly kind of worry. Well, worry is the wrong word. They're concerned about how to do this, and really working to try to ensure that they put in place those characteristics, those actions is a better word, those actions to sustain the journey to high reliability. And one of the key things is leadership focus. I mean, this is driven by the CEO and the Chief Nursing Officer, no question about it. So the CNO, though she may be a spokesperson quite a bit, she has got full and 100% support from the CEO. Absolutely critical. The message is repeated again and again and again, so everyone knows how important this is. This is the shared mission. They use an internal web page to share their performance. They have a daily email blast out to all employees about, it's quick. It's a quick one about safety. They periodically highlight a story. It's stories that move people. All of you probably know that. That data is just about worthless. Information that you can glean from the data is getting better. And then when you take that information and describe it in a story, that's what really works to move people and motivate people. They have a Speak Up award, so they're rewarding people for actually, reporting of errors and potential errors. I already mentioned that they're using safety as one of their organizational values. So in the near future, when you look to the Central Peninsula Hospital's website and you look to their values, you'll see safety. Not yet, but that's coming. They're measuring. And when they measure and then again report, they're measuring not only quantifiable data, but qualifiable data as well, too. So they're telling that story as well, too. And then lastly, celebrating successes, of course, all critical components to actually changing culture. That's the journey. Again, this is a bit for your review. It's too busy to really discuss in a slide, but it's kind of a neat slide, again, from Studer Group, that talks about where things kind of, if you don't have it, where things happen and how change gets short-circuited. So as you think about kind of what you need to make change, kind of take a look at this and look what's